Dr. Miller, one of the great things about the Medicare Part D program design is that it harnesses the forces of choice and competition to reduce costs while improving the options for seniors. Premiums in the program have been basically flat over the last few years, and seniors truly love the program. I noticed that MedPAC has examined and endorsed a competitively determined Medicare planning bidding system for the future of the Medicare program. Can you talk about the merits of this approach and how it is similar to or different than the Medicare Part D or Medicare Advantage? And then could you also explain to what extent would it free Congress from annually having to adopt price controls to patch Medicare's fee-for-service system?
Okay. The first thing I just need to clear up, we did not endorse it. We did publish a chapter and sort of discuss the issues, and what we were trying to do is kind of strike a balance between, strike a balance in the policy conversation. You could take approach broadly in Medicare like you take in D, where you say there will be a competitively set government contribution, and then the beneficiary would select a plan, and the plan is either a managed care plan or fee-for-service, even though that's not a plan, and then pay the difference depending on how expensive it is. So that's the thought I believe you're chasing here. And what we said is that that's a legitimate conversation that should occur, but there is a set of design issues that become extremely important here, and how well this is done and how successful it is. One right off the top that I think a lot of people miss is in the private sector, there has been tremendous provider consolidation over the last decades. Your questions about the site-neutral payments are all about that kind of phenomenon. And to the extent that there's been greater consolidation, commercial insurers have had a really hard time holding down payment rates because you have a very consolidated provider in certain markets. So approaching these competitive models, you have to be very conscious of how you're going to extract reduced prices from these providers who in the private sector actually have consolidated positions. In Medicare, you have administered prices, so you don't deal with that. Now, the technical questions about how you deal with that are probably beyond a 5-minute answer. But the first thing to keep in mind is if these things aren't done right, they can actually cost Medicare money. But there are technical issues to navigate around that. A couple of other issues are things like this. Do you standardize the benefit, which would say it's very clear to the beneficiary, very clear to the Congress what they're paying for and what works and what doesn't work? Or do you allow complete innovation in the benefit design or something in between? The MA plans, you have to provide certain services, you have ability to play with the cost sharing. And so you got to think about that. Another big issue that you have to think about if you go down these roads is where you set the government contribution. If you do it at a national level, then there are certain parts of the country where everybody pays, fee-for-service or a managed care, and other parts of the country where everybody gets a premium rebate, for lack of a better word, whether you're in managed care or fee-for-service. If you do it within the market, that's probably a more rational way to go at it, but there's probably then some subsidization that's occurring across the country, and you'll have to deal with the implications there. So what we tried to do, and then I hate that this came off as an afterthought, what are we going to do with the low income? So if there is a premium support here, then how are the low income going to be handled? So what we did in this report is just blocked through a set of issues and said if we're going to have a serious conversation about this, there has to be answers to each one of these issues. And we kind of went through the pros and cons, and we did a little simulation, very static, not high science, but a little simulation of some of the distributional impacts. And I would refer, if you want to have this conversation, refer you to that.
Very good. Thank you very much. In November 2012, CBO issued a paper on the offsetting effects of the prescription drug use on Medicare spending. Basically, proper adherence to a prescription drug regimen in Medicare Part D would provide a savings from hospitalization in Medicare Part A. Can you talk a little bit about this spillover effect and savings? Also, do you think that eliminating duplicative medications and proper monitoring of dangerous drug interactions could also add to savings in the Medicare program.
I mean, we decidedly have been, we had some discussion of this on opioids just recently, decidedly concerns about over-medication and, drug-to-drug interaction and that type of thing. And you want to deal with that, not just for savings reasons or even despite whether it saves or not. You want to focus on that because of the impact on the beneficiary. We're in a little, our research is in a little different place than CBO's. We've seen that, we've talked to them, we went through it. I believe they've done it very carefully, and there's a lot to commend it. Our own research has somewhat more ambiguous results. We see this effect where you get the savings on the hospital side, your better drug compliance, reduction in hospital effect. But the hospital effect kind of goes away after 6 months, a year. And we're a bit confused by that, and we're still kind of churning on it ourselves. Great if you should probably have compliance for medical and clinical and all the rest of the reasons anyway. If it has a savings effect, great. We're having a little trouble, coming to the same conclusion.
All right, thank you. I yield back, Mr. Chairman.